I would like to welcome you into today's AHN Nephrology Education webinar, and today's series number 86. So today's, my name is Gina Francis Makwabe. I'll be chairing this session together with Dr. Frida Mowo, who is a consultant pediatrician and nephrologist working with Africa Healthcare Network in Tanzania, and also Dr. Jonathan Wara, a physician and nephrologist working with Aga Khan Teaching Hospital in Nairobi, Kenya. So today's topic is a very interesting topic, and the topic is implementing sustained low efficacy dialysis, SLED, in ICU. And it's a great honor to introduce.
Introducing Professor Santosh Varughese. Professor Santosh Varughese is the professor and head of Department of Nephrology, Christian Medical College, Vellore. Dr. Varughese is a product of CMC, is an undergraduate and postgraduate, and as well as nephrology. Subsequently did his fellowship in nephrology at the University of Toronto. And he has now built up a wonderful program in nephrology, and there are a number of, I think there are 12 faculty in the department doing wonderful work in various areas, teaching, research, and patient care. And I think Dr. Santosh is no new person here. So over to you, Santosh. Welcome. Thank you very much for coming here. I think this is the fourth time that you're coming here today to help us. Thank you.
Thank you. It's always a joy to be back in Africa. I mean, I've enjoyed coming there in person every time. So I've kept my topic more academic than probably necessary to help trainees if they are listening. So the topic is talking about SLED, which is one of my favorite topics. I still remember when SLED first came on the horizon. At least we first came to hear about SLED during our training, and it had just made its appearance in the world just a few years before we joined the department for our nephrology training. So I'll start with the case of a patient that we would see, a 35-year-old man with a road traffic accident with crush injuries and a wound infection in the surgical ICU with SIRS and is anuric. And the surgical intensivist call us for dialysis support for somebody who's anuric. And when we go there, we find that his blood pressures are 80/50, his potassium is 6.9, his bicarb is 9. Which renal replacement therapy will we offer? It largely depends on what we have and what we're used to. But in the perfect world, what we offer. So that's our premise before we start the session. I have found this very interesting that in 2013, January, there was an editorial with this title, New Nephrologist. That is the nephrologist who is good at intensive care. So in a sense, because we handle a lot about the fluid electrolytes, we are probably the next best bet after the intensive care physician to take care of our patients who become sick. So we are all called to be new nephrologists who've got ICU care handling ability in addition to managing nephrology. So the overview is talking about SLED with circuit and preparation, and predominant talk will be about the evidence of SLED versus CRRT. I think we should take the topic head on, and then a newer tweaks in SLED prescription, with some of which we can adapt easily, some of which are a little bit more difficult, but are on the horizon and will soon come our way. So it's very interesting. Look at the history of hemodialysis. It was 1945 that Dr. Kolf did hemodialysis on a 6-7-year-old lady who had uremic coma. And the person was given dialysis until she woke up. And that was 11 hours. So in a sense, the first hemodialysis done, or the first extracorporeal renal replacement therapy done, was SLED. So we are actually talking about a therapy which has been there for a long time, although it was not recognized as such. So the fundamentals of SLED are, it is slowing down what we regularly do with hemodialysis, doing for prolonged periods using conventional hemodialysis machines with modification of blood and dialysis. Because of that, it combines the advantages of CRRT and intermittent hemodialysis. The gradual solute and volume removal of CRRT is applied in SLED, and therefore there is hemodynamic stability. And the high solute clearances as in intermittent hemodialysis is also achieved. And you don't need the expensive CRRT machine, which is the big plus, and the costly customized solutions, which are also expensive. So the machines and the solutions are both expensive. The staff training, not so much, but of course we need to train the staff to do CRRT as well, but that's not so much. Another important thing is it allows interruption of renal replacement therapy for diagnostic and therapeutic procedures that patients in ICU will require, rather than reducing the amount of renal replacement therapy we give them. It's got a lot of names, sustained low efficiency dialysis, and some people add a daily to it. They say sustained low efficiency daily dialysis or slow low efficiency daily dialysis. Some of the other names are slow continuous dialysis, extended daily dialysis, and somewhere I found even the term go slow dialysis has been used. But the term that is currently, I think, in vogue now, and we should be using more and more in our practice is PIRRT, this prolonged intermittent renal replacement therapy, which I think is most appropriate. The SLED circuit is similar to the hemodialysis circuit. We have blood flow and we have dialysis flow, just like a hemodialysis circuit. There's nothing different, but it's called the hybrid therapy because of the benefits that it portends. Now, this table, I had written a chapter in this, I written an article in this journal a few years ago on talking about the different modalities of RRT, and I made this table there. It lists all the blood flow rates, dialysis flow rates, and so on of all the different modalities. So you can see the blood flow rates 100 to 200, dialysis rates 100 to 200. I'll discuss that in the subsequent slide. So 100 to 200 blood flow rates and 100 to 200 dialysis flow rates. However, in Toronto, when we were doing SLED, the dialysis rate, the machines could not be lower to less than 300 ml per minute. In India, we used to have a Fresenius machine called ARRT Plus, 4008 ARRT Plus machine, which used to lower the dialysis flow to 200 or 300. But Fresenius killed that machine because obviously they wanted people to buy the 5008 machine. So in that, if you take just to understand the clearances that happen, if you do a blood flow rate of 200 ml per minute and the dialysis flow rate of 300 ml per minute, that works out to about 150 to 180 ml per minute of urea clearances and about 1.2 kT by V in an 80 kg person. What has been known from a long time is that if you give kT by V more than 1, it improves survival. And if you give 0.92 at least six times a week, it is better than giving 0.94 3 times a week. This is one of the studies that came up about 20 years ago. KDIGO says you must give about 3.9 per week. So the 3.9 per week is with a frequency of minimum 3 times a week. And if you monitor the delivered dose minimum, it should be 1.2 per treatment. There is no evidence that more frequent treatments have better outcomes, but that is dictated by hyperkalemia, volume excesses, and hypertension requiring stoppage of therapy. The duration is at least 6 hours, although 8 hours is probably better. To 18 hours typically, except C-SLED. Just keep this term in mind. We'll come to it later. And the urine reduction rates are of CVH is 23.3. Which comes out to about 53, and SLED is 11.7, which comes out about 52. So about 12 hours of SLED is about equivalent of 23 hours of CRRT. So it's it's not bad. If you give 12 hours of SLED, you're actually giving a similar URR of a 23 hours, or almost the same day. And if you give UF for 400 ml per hour on SLED, it's roughly equal to 126 ml per. The timing advantages timing can be as per convenience. There are people who do SLED at night to keep the daytime available for doing tests, etc. And in about 40% of cases, you can avoid anticoagulation, or you can use a small bolus of 1,000 or 2,000 units and a small continuous infusion of 500 or 1,000 units per hour, so that you don't really cause much clotting, risk of bleeding, and the APTT is kept just a little above normal, about 1.5 times of normal. Heparin requirement is much lower than that of CRRT. If you do daily SLED, you need to give phosphate. So that's another thing which we'll look at in different studies. Now, coming to the what the study, this talk will mostly consist of comparing the different RRT modalities, SLED and CRRT. I've talked about intermittent hemodialysis also in the middle at some points with respect to its efficacy, safety, mortality, benefits, metabolic and acid-based control, and cost. Cost, not so much. So when the first paper came out, a prospective study of 25 patients giving extended daily dialysis comparing to 17 patients with CRRT, they found no differences in the mean arterial inotrope pressures or inotrope requirements, and the mortality seemed to be higher in this group, but they also had higher Apache 2 scores. But they found it was cost effective by reducing the need for constant monitoring of dialysis equipment and reducing the nursing workload. So this was a study which showed the blood pressure is okay, but the mortality was higher, but there were also sicker patients, but it was cost effective. Then came a few nice studies. This is a study by Dr. Mark Marshall. I believe he works with Baxter now. He talked about 18 months experience since July 1998 of 12-hour nocturnal treatment, about 10 and 10.4 hours in severely ill patients who with intermittent hemodialysis could not be done. And he described his experience of SLED, and he found that hemodynamic stability was maintained. The UF goals were a little less per session than expected, than target, but the KTYV was good, and some of them had mild hypophosphatemia, and mortality was as expected for the Apache score. So he said that it's something which is feasible to be done. As can be seen, as expected, everything reduced appropriately, except phosphate, which required replacement because of its fault. This study in 2010, I'll talk about some of the relatively more recent studies. This study looked at hemodynamic tolerability and feasibility of SLED in particularly ill patients with AKI. So patients were unstable, but given either SLED or CRRT, and the odds ratio of hemodynamic stability was 1.2, which crosses 1. So you actually know that there's no hemodynamic instability additionally with SLED compared to CRRT. And they quoted all the different randomized studies which have compared the CRRT and intermittent hemodialysis for hemodynamic instability. And they found that actually none of the studies there was any significant difference in CRRT and intermittent hemodialysis for hemodynamic tolerability. But must know that the studies incorporated patients only those who were able to be tolerating it to begin with, only they were incorporated in the study. There was a question, is longer dialysis harmful? Today, years later, we know that it was not harmful, but they had to actually show it. The study, 75 patients, SLED, 10 hours versus 6 hours, and they found that actually the complications were similar in the two groups, and there were and the blood pressures and the norepinephrine requirement also was similar. So actually, longer SLED is not harmful. How about children? Switching gears to using SLED in children, conceptually is similar to using in adults, except for if you're using it, we need to know that we use much blood flows, and the blood flows reach 150 or more only if the child is more than 40 kilos. Otherwise, you use lesser blood flows. Now coming to the different studies showing, looking at mortality. So this again, Mark Marshall study from Africa, sorry, Australia, I'm telling Australia, New Zealand, and Italy, 3 ICUs, and they looked at mortality rate comparison after switching from CRRT to SLED. CRRT to SLED for EK, 3 ICUs, 3 different countries. And what they found is that actually there wasn't any difference in any of the parameters that they actually looked at. And the mortality rates expected and observed pre and post did not change. And there was incidence ratios for death associated with switch was squarely on 1 with changeover to SLED from CRRT. And the 10% increase in SLED utilization. Remember, PIRT is SLED is actually bang on 1, meaning that there was no change in mortality because of a switch policy change switch to SLED. This study is one of several meta-analysis which I will show, looking at various things that they have looked at. This study looked at 2000 to 2014, 7 RCTs, 10 observational studies, looking at extended hemodialysis or hemodiafiltration. So they combined hemodialysis and hemodiafiltration. And what they found is that in all these studies, there was no difference in the mortality in RCTs or observation studies, renal recovery in RCTs or observation studies, fluid removal in both the studies. This paper is in 2017 systematic review and meta-analysis looking at 1,564 patients and 18 studies. And again, they found if you were to say that this is actually on the favoring SLED because it actually crosses, it does not touch, it's not 1. Therefore, were to combine everything, we'll say that maybe there's a benefit with SLED, but when they look at only RCTs, it just nearly favors SLED. Actually, as you can see, it touches 1. Therefore, it is not really favoring SLED. So actually, what we know is SLED and CRRT was similar. Also, with respect to 30-day mortality, hospital mortality, ICU mortality, although the forest plot is towards the SLED side because it touches 1, we have to say that subgroup analysis also concurred that the two were similar to each other. This is a little more later one of 2015, comparing the different studies of CRRT, hemodialysis and SLED, or CRRT versus SLED. So this is a progressively larger cohort of people. And here you can see that this bang in hospital mortality, bang in middle, in hospital mortality versus CRRT or versus intermittent hemodialysis or SLED, and CRRT versus SLED, all bang in the middle or touching 1. So you can say that they're actually similar. ICU mortality similarly, again, a bang in the middle, the CRRT versus SLED also, ICU mortality similar. Dialysis dependence. This is where CRRT actually initially said that they were less likely to be dialysis dependent. And there again, it's bang in the middle with no difference between any of these. So this is a paper by Dr. Abhijat Kichulu, who's in Toronto right now, published in BMC Nephrology. He looked at 158 CRRT and 74 SLED patients in 7 micros AKI registry. They do a lot of work on AKI, including the acute start study, which was published a few years ago, in which they gave SLED without hemodialysis, so without anticoagulation for 8 hours, and SLED versus CRRT mortality at 30 days, there was no difference at all. The 30-day mortality, 30-day dialysis dependence, or early clinical deterioration all was similar between CRRT and SLED. Dialysis dependence at 30 days was similar, unadjusted and adjusted. If they use SLED as predominant dialysis modality or if it's exclusive RRT modality in the first 3 sessions, again, all the different ways it was analyzed, there was no difference with SLED versus CRRT. This systematic review came out in 2017 using a larger number of patients, and again they looked at the renal recovery. This study looking at renal recovery. Okay. So this renal recovery found that actually, although some of the initial studies promised renal recovery was better, there was no difference in the study. initial studies we seem to show a benefit of CRRT, but when you put everything together, there was no difference. Again, the hospital doing recovery, patient survivors, ICU recovery in all patients, ICU recovery in survivors, all seem to be right in the middle. The phase 2 renal recovery, when we looked at later studies, actually showed there was no difference, although it tilted towards the right, favoring SLED, it crosses 0, therefore there's no difference. This paper in 2016 looked at patients with renal recovery, alive and not requiring dialysis, or reasons for non-recovery. These are patients who compared CRRT as well as intermittent hemodialysis. So this is not SLED, intermittent hemodialysis. What they found was CRRT seemed to be better than in terms of renal recovery time compared to intermittent hemodialysis. In the 9 days, first 9 days, there was a significant difference. However, by 65 days, it balanced out. So although there seemed to be a 3-month advance for recovery in CRRT hemodialysis, that was naked by the end of the year. Poisons, can you SLED poisons? Now, intermittent hemodialysis or hemoperfusion, they are treatment of choices of poisons, and CRRT, they are not treatments of choice. But if there is a hemodynamic compromise, which one would you choose? So logically, because you've got a bigger gradient and faster dialysis flow, the SLED will be better in that instance, although that has not been studied. This is just a conjecture. Now, Robert Chesson changed practice in University Health Network at Toronto General Hospital to avoidance of CRRT entirely and switching to SLED completely on the basis of this paper, in which he showed that CRRT SLED was a huge cost difference in the citrate or heparin. There was huge cost difference using SLED with no advantage, and this became the reason why there was a change of practice and the hospital no longer offers CRRT for the patients there. 2013, looking at the cost benefit analysis, again showed that all cost reimbursement favored SLED. So overall, the cost you can understand easily the same. I haven't not used substitution fluid, the cost will favor SLED. Now there are some modifications to improve on that we'll discuss in the next minutes. Can we use regional citrate anticoagulation the way we use CRRT? Is that possible with there is this paper 2008 CJSN in which they gave 4% sodium citrate with a line the citrate by infusing calcium chloride, and they found that they required a higher dose of calcium infusion than for CRRT they were using. The citrate complex was removed efficiently and there were no metabolic complications. There are several studies looked at with no complications. In this paper, 807 patients, all citrate levels were levels were lower, and therefore they required replacement with higher amounts of calcium. Now, anticoagulation can be used in liver failure patients. That should be a strict no. This paper, the authors in this paper decided to study when you do with restricted anticoagulation. We would normally use no heparin SLED because they would usually have prolonged prothrombin times and the circuit is less likely to clot. Therefore, we would use SLED without giving heparin for these patients. But they asked the question, can you use regional anticoagulation in liver failure patients with SLED? And they had patients with a single batch, batch system, and they had liver failure for them and patients with decompensated cirrhosis, and they numbers the metabolic parameters, and this paper was able to demonstrate the safety. But they did demonstrate safety. This is still not a treatment of choice. We can do need for more renal replacement therapy. How about, okay, I'll start from here. So this study, they asked the question, can we use SLED with regional anticoagulation for liver failure patients? What we wouldn't actually do regularly, but nevertheless, they asked this important question and they tried to venture an answer. And what they did was they chose 24 patients and with decompensated liver cirrhosis or acute liver failure and AKI. And they gave SLED for these patients with regional citrate anticoagulation. There was improvement in metabolic parameters, and they were able to demonstrate the safety in these patients. There was a transient rise in citrate, which came down with time. So, regional citrate anticoagulations for renal replacement therapies, their position statement by the Italian Society of Nephrology said that they can use it for all RRT modalities. And commercially available citrate solutions are safe and effective for SLED as well, and only limited laboratory monitoring is required, with most patients not requiring IV calcium infusion, unlike the CRRT where we would require to give them IV calcium necessarily. And the incidence of metabolic complications was low, and most of the infused citrate was removed by the treatment itself. So actually, while not ventured by most of us, this is something that can actually be done. Now coming to something where SLED has outfoxed CRRT is sustained low efficiency daily diafiltration. So basically this is SLED plus simultaneous online hemodiafiltration. If you remember with me, CRRT, we are doing hemodiafiltration by giving replacement fluid that comes in pre-packaged bags. Whereas if you do SLED and you do hemodiafiltration, that is, you remove large amounts of fluid and you replace them with diafiltration fluid that is manufactured by the machine using the products that they have and the concentrates of the chemicals that we provide. So you actually have got SLED combined with CRRT. So this is actually not SLED versus CRRT. This is SLED combined with CRRT. So this very interesting paper, 2004, gave 100 ml per minute for 8 hours, daily or alternate days. And they showed in the small study of 56 patient treatments, there was no intradialytic hypertension. So you have the advantage of CRRT by giving replacement fluid, but it's way cheaper because it's manufactured online by the machine. And there were no complications. The KT/V was good, and they removed large middle molecules as well because of hemodiafiltration. So this paper in 2012 looked at 21 consecutive patients whose they knew the mortality risk was more than 50%, and they gave 6 to 23 hours. Median was about 10 hours at least, and they used a large conversion volume, 17.8 liters per hour, and like we would do in hemodiafiltration. And they found that hemodynamics was very good. Hardly anybody had hypertension. Again, historically, when they compared to CRRT, this is not a trial against CRRT, so they didn't have a direct comparison, but a historical comparison. It is lower cost and lower mortality than expected. They expected a larger number of patients to die, but the 28-day survival was 81% and 90-day survival was 52%, which is far more than what they expected, showing that actually, if you really want, you can combine the benefits of SLED and CRRT together in this extended daily high volume diafiltration. And this is a picture showing the mortality graph. There was a drop in mean arterial pressure as well as norepinephrine used in the first few sessions. Thereafter, it petered out, and thereafter there was no difference. Now coming to, remember I talked about SLED in one of the previous slides. We had a patient in Toronto who had a lung transplant and had acute kidney injury. And I think we gave him SLED 24 hours 7 days a week, 24 hours a day, 7 days a week for over 3 weeks. So this study in critical ill cancer patients who are oligoanuric and hypotensive, requiring large volumes of fluid, multiple pressors, they were given SLED, this SLED round the clock. So in this study, the median duration was 50 hours continuously, ranges between 1 hour to 32 days, and the dialysis flow was low at 100 ml per minute. And they found that they were able to keep good mean arterial pressures, and they achieved good ultrafiltration. And the mortality is seen here. Basically, they were showing that it can be done, and the people died because they were sicker, not because of the therapy. Now, coming to unique situations. Now, people with CNS bleeds or intracranial pressure situations, we are generally told that CVVHDF is better for these patients rather than intermittent therapies like SLED. That is the general teaching. However, this group decided to put it to the test, and in Taiwan, they actually studied the patients who had intracranial brain hemorrhage, and they looked at the hemodynamic effects during SLED versus CRRT in these patients. It's a crossover study. Now, what they did is they monitored intracranial pressures very interestingly in these patients. They had 10 patients who had brain hemorrhage and who had intraventricular drain and ICP monitors. So they gave them CRRT on the or SLED on the first day and alternate day and alternate therapy on the next as a crossover with 1 to 1.5 kgs per 8 hours. And what they showed is that this is a graph showing this intracranial pressures. But they show that the intracranial pressures percentage change, actually transient change about the middle of the session, but they equaled out at the end. And between the two therapies, there is no change in the intracranial pressure. So contrary to what we are taught about using CRRT preferentially for people with raised IC intracranial pressures, that actually may not be true, as was shown by the study which measured the intracranial pressure. So to conclude my talk, we talked about efficacy, we talked about the safety, we talked about the mortality benefits or no mortality difference between CRRT, metabolic acid-based control, cost, which is a big plus for use of SLED, and the modifications that are possible, both the SLED with diafiltration as well as SLED, and renal citrate anticoagulation for those who want the benefit of renal anticoagulation and yet prefer to use SLED. There was this paper in 2001 in the JSON in which Raymond Manholder from Belgium had a paper in which he asked a question: what is the renal replacement therapy of first choice in intensive care patients? And he actually was writing for the benefit of using SLED. And my conclusion would be, like he said, SLED is the RRT method of first choice for ICU patients. And with that, I close, and thank you for your patient listening. And I'm open to trying to answer any questions that there may be.
Thank you so much. I'm sorry.
I'll also be sharing the slides afterwards, so we're happy to go through them.
Thank you so much, Professor Santosh, for the wonderful presentation. I'll be moderating the question session, and I'll start by reading the question from questions and answer session. Dr. David Atue is asking, how do you replace phosphate in your practice in SLED and CRRT?
Yeah, so while we were in Toronto, we had something called fleet enema, which is phosphate in the enema used for patients, and we used to add that to the dialysate. Now, I'm not certain that is available, so we actually give intravenous phosphate, or for others who are on NG feeds, we give them neutral phosphate syrups to increase the phosphate. So it's given intravenously or by a nasogastric tube. Where those who can tolerate orally, we give them oral phosphate.
Thank you. Another question from Dr. Nahla Alam asking, I think he wants to know about SLED prescription for children.
Yeah, so I'll just show that slide again. Yeah, so because the body weight is low, we have to keep a lower blood flow rate. The dialysate flow rate is kept again as low as possible, depending on the machine we have. Preferably 100 to 200, but if only 300 is possible, we keep 300. But the blood flow rates are kept much lower for children.
Thank you. So moving to the chat box, we have one question from Dr. John Mumbi. He says he noticed in the diagram in SLED, both blood and dialysate move in the same direction. Is that right? If yes, can we use the same dialyzer for IHD and just change the direction of dialysate flow and blood flow?
Yeah, so that's a good question. So that diagram did show the two is similar because remember we are trying to slow down the rate of exchanges of toxins across the blood, across the dialysate membrane. So giving them co-current or other words in the same direction actually allows you to equilibrate the dialysate much slower, lowering the gradient. Yes, to answer the second part of the question, yes. Like I began my session, the SLED is done with the same hemodialysis machine, the same hemodialysis cartridge or the dialyzer, but lowering the blood flow rate, lowering the dialysate flow rate, and for a much longer duration.
Thank you, Professor Santosh. We have another question from Dr. Pasco Rugajo. Dr. Rugajo, if you can unmute your mic, you can ask us, I think, straight.
Hello.
Hi, Pasco.
Hi. So nice to hear from you, Santosh, and it's always great to see you, our lifetime. I remember the days when I was accompanying Shibu to Miku and Siku for patients who needed SLED, but also were on inotropic support. So my question is, what is your personal experience on the outcome for patients who need both SLED and inotropic support at CMC?
So we haven't actually studied it. Maybe we should, because see, dialysis support or the RRT support is only a small part of what they require. Most of it is because the underlying condition, either a post-surgical problem or underlying malignancy or trauma or infection in the medical ICU. So we haven't studied it. We do offer CRRT also. I think we weren't offering when we were there. So we offer CRRT also. Again, because CRRT requires larger volumes, it's more of replacement volumes, it's more expensive. But to answer your question, we haven't studied as to how much is SLED versus CRRT, if that's what you're asking of how the patients have done. In our my rough statement would be there's no benefit of one over the other.
Okay. Thank you, Santosh. Thank you so much.
Thank you, Dr. Pasco Rugajo, for being with us in this session. So is there any other panelist or any other who would like to maybe comment or ask any question? You are welcome. You can use the raise hand feature. If not, okay, Dr. Mazhar Amirali from Muimbili. He's asking, you mentioned that patients on SLED can do away without anticoagulation. What is the risk of clotting with slow blood flow rates?
So like we would do for somebody intermittent hemodialysis, somebody who is post tooth extraction or a post ulcer bleed, we would give them saline flushes, and nurses would tap the dialyzer just to make sure that the blood doesn't clot. So that is something that it's a little bit more labor intensive because you have to keep giving flushes and removing the flushed out saline fluid. So every 15 minutes or half an hour, you have to keep giving 100 to 200 ml of at least of dialysis of saline, which they have to remove as the ultrafiltration. Otherwise, there'll be excess of fluid in the body. So that is the way that people avoid using the anticoagulation. But like I said, you can use a small amount of anticoagulation, especially in those who have a normal prothrombin and partial thromboplastin type, so that you can be absolutely sure that you won't be clotting the circuit at all. But since these are all going to be typically a single-use circuits alone, we don't have to worry about preserving the dialysate, but only that they should not lose much blood. So if at all there are some clots formed, there'll be very small clots.
Thank you. So another question is from the same Dr. David Atuhe about phosphate. He's asking, are you able to predict by how much each of your prescription for phosphate raises the phosphate level?
No, there are. I've not worked it out. See, phosphate actually doesn't move as much as potassium and potassium does. So our sodium does. So I'm not sure that the formula we use for sodium will work. There is a formula for sodium. I don't think it works. So the short answer is no. I don't think we can predict. What we can say is studies have shown that the phosphate drops, but it really doesn't drop to that significant amount, because most of the time they're doing it in hypercatabolic patients, in which phosphate is also being generated at a much higher rate. So it doesn't often cause hypophosphatemia.
A little off of topic, if one doesn't have access to heparin, can enoxaparin be used as alternative anticoagulation?
A good question. There's no reason why not, except that remember, we cannot monitor it unless you have factor Xa assays. So we haven't used it. I haven't come across any papers suggesting that we can use this this low molecular weight heparins like enoxaparin or dalteparin. I haven't come across any papers, so I don't think it's there in the literature. But I don't see why not, except that we cannot monitor, so we have to be judicious in using it.
Thank you. And Dr. Huda Krabi from South Africa, she's asking, how do you approach thrombocytopenia with SLED?
That's a good question. So again, depends on the cause of thrombocytopenia and the magnitude. So if the patient is septic with a DIC and the thrombocytopenia, I think we cannot use heparin at all. Alternatively, the patient's got the immune-mediated thrombocytopenia. Again, we wouldn't be able to use heparin at all. We have to use only no heparin dialysis. The others, we could use low volumes, low amounts of heparin, like 500 to 1,000 units per hour of heparin as an infusion for these patients.
Thank you so much. So if there's no any more question, can I return the session to Dr. Vincent Lloyd? Dr. Lloyd?
Thank you. Thank you very much, Santosh, for this excellent presentation and answering all the questions very patiently. Extremely grateful for having come on board again and the support time, and please expect more calls.
Sure.
Of course, not going to be very, very frequent, but definitely will trouble you again, Santosh.
Sure.
Thank you so much.